So now we're going to treat arterial hypotension, and let's move to the third item with Dr. GODET.
Thank you very much for the invitation. I'm very pleased to talk about therapeutic approaches to manage blood pressure. I'm Thomas GODET, and I work in university hospitals in Clermont-Ferrand. I have no relevant conflict of interest with this presentation. So I just want to come back to basics and to physiology very quickly, just to recall you that mean arterial pressure is determined by the product of cardiac output and systemic vascular resistance. As you know, systemic vascular resistance might be treated by vasopressors. You can influence vascular tone with vasopressors. On the other side, cardiac output is determined by the product of heart rate and stroke volume, and of course you can change stroke volume by adding fluid loading, fluid challenges to the patient. And as you know, you all know the Frank-Starling concept of preload dependency. How does it work? When you do some fluid loading, you can increase the filling pressure within the vascular system, and you modify the circulating volume of blood, of fluids, within the vessels, so you can modify the content. On the other side, when you change the vascular tone by adding vasoconstrictors, vasopressors, you can change the same mean filling pressure by changing the container, the vessels. So you have two different therapeutics you can use to increase mean arterial pressure or cardiac output in general. The first step, to my point of view, is to optimize circulating volume of your patients. And finally, that's exactly what we do every day in the operative room. When we have some kind of hypotension, we just open the fluid and it goes through in the vessels. So you can use crystalloids. I won't go through the debate about crystalloids or colloids today. So you can do fluid challenges to improve stroke volume and finally determine your stroke volume reference, which is the one you're gonna follow all surgery long. So you can use algorithms such like this one, which is the one which has been published by the French Société of Anesthesiology and Intensive Care. And finally, the main goal of it is to place your patient on the preload dependency heart function by improving the vascular content. But to do so, you have to use monitoring tools, and you can go back to the previous presentation to be convinced that you need to use monitoring tools. But you have to recall that the only response to any decrease in mean arterial pressure is not, the response is not fluid loading at any time. As you know, we already talked about this earlier. Sedatives, analgesia, perimedullary anesthesia gonna change the vascular tone and gonna decrease the vascular tone. So finally, you can use vasopressors to counteract those effects and not fluid loading, which should be correct. So what are the vasoactive drugs you can use during any kind of circulatory shock? Usually in the OR, we do use phenylephrine, norepinephrine, and most of the time we use ephedrine. So I'm going to go through those three types of catecholamines. Ephedrine, as you know, combines the hemodynamic effects of norepinephrine and epinephrine. It has an indirect action. Finally, it just favors the release of endogenous norepinephrine and epinephrine. And as you know, it has an exhaustible effect, meaning that when you go beyond the 30-60 milligrams, there is no more effect, and of course you can't use it as a continuous infusion. Maybe some of you might use phenylephrine. Phenylephrine is a pure alpha agonist, so it's just gonna increase vascular tone. It has no beta effect. I just want to stress out a major point to my point of view, which is that when you use phenylephrine, you just have to be sure that you have a preload-dependent patient. I mean that if you have a preload-dependent patient, which is a patient which is here in the Frank-Starling curve, finally, when you add some phenylephrine, you're gonna increase mean arterial pressure, but at the same time, you do increase the stroke volume, which might be beneficial to your patient. On the other side, when you have a patient which is preload independent, as shown here, yes, when you add phenylephrine, you do increase mean arterial pressure, but at the same time, you just decrease the cardiac output and the stroke volume, which might be highly detrimental to your patients. So I fully agree with the conclusion of this paper, which says that you can't use phenylephrine without any cardiac output monitoring tool. And to my point of view, since phenylephrine has no beta effect, it has just an isolated alpha effect, which might be detrimental. To my point of view, at least, phenylephrine should not be used anymore in any operative room without any monitoring tool. Finally, we have norepinephrine, the third choice, which has a strong alpha effect and a beta effect. I just go back to the Emmanuel Futier study, IMPRESS study on the effect of, I fully agree, of an individualized management of hemodynamics of patients during a major abdominal surgery. This study randomized 300 patients at high risk of postoperative complications. And in the intervention group, first, norepinephrine was used as a continuous infusion at the start of the induction. But before that, at any time, there was an optimization of fluid with fluid challenges of the hemodynamic of the patient. So we just compare norepinephrine to ephedrine, and there are two different strategies to optimize this. And finally, the main conclusion of this paper is that in the intervention group, you just decrease the primary endpoint, which was a composite of organ dysfunctions by 7 days after the surgery, and significantly. My main conclusions would be that fluid loading and vasopressors are complementary. You can't use one without the other. You have to select one depending on the clinical situations. Either you lose some vascular tone due to sedatives, for example, or you lose some fluids like during an acute bleeding. Which fluid should we use? Maybe crystalloids in the OR, maybe balanced crystalloids, but I won't go through this point. You might use vasopressors, and I hope I have at least started to convince you that you shouldn't use phenylephrine anymore. And norepinephrine and ephedrine are the best choices, to my point of view at least. But this requires monitoring devices. They are going to depend on the risks of the patient, of the risk of the surgery, and what you have at your institution. And you need to use those monitoring using validated algorithms. Without any algorithms to improve your hemodynamics, even with a monitoring device, you're not sure that you're going to have the right choice. And finally, I want to thank you for your attention.
Thank you, Dr. GODET, for this lecture. I have a question, a comment. How do you do in your daily practice with vasopressor? Do you use ephedrine as a first therapy and then norepinephrine, or do you use systematically norepinephrine as it was done in the IMPRESS study?
Yes, that's a good question. On my daily practice, I use both. Meaning that if I have a high-risk surgery and a high-risk patient, I'm gonna use norepinephrine from the start of, even before the induction of the patient. If I have a young patient for a very simple surgery, I would say, I might use epinephrine, ephedrine, sorry, just to counteract the primary effects of the sedation of the induction, and afterwards, if it requires more vasopressors, I'm going to use norepinephrine.
And when you use norepinephrine, do you systematically use an hemodynamic device to measure the cardiac output and the other determinants of the blood pressure, or not?
If I could, I would do so. But most of the time, for small surgeries, we use when we have low concentrations and low amount of norepinephrine infused, we do without any monitoring device, but that might not be sorry, the best practice, actually. But that's real life that I say today.
Okay, yes, the same.
Just to reinforce a message that has been very nicely been put forward. There's this issue of monitoring preload dependency. So there are reliable and accurate, non-invasive monitors that allow us to have, let's say, in nearly all patients, a non-invasive monitoring tool of preload dependency. And there should be probably no limit to this, because it's non-invasive, and it provides this information about preload dependency, which will condition the choice of your vasoconstrictor. And then you had a second algorithm, which is based on the e-sfar, now 12 years old algorithm, which is maximization of the stroke volume. So as you saw in this algorithm, there is no issue of preload dependency. So even if you are not preload dependent, you can still optimize your stroke volume. And this is maximization of the stroke volume to maximize your oxygen delivery. So those are complementary. And the issue is that probably 20% of patients should be considered at intermediate high risk and should benefit from stroke volume monitoring. And there's no, except for ASA1 short duration general anesthesia procedures, but there's no limitation for monitoring preload dependency. Do you agree with this?
Yeah. Sorry. I fully agree with this, but all of us, we know that for some, I don't know, economic reasons, sometimes we do not have monitors for any patients in big operative rooms, in many of those. So I would say we need to monitor any patient in the operative room, but sometimes we got some financial constraints.
Which should not exist, because it's been shown in the French medico-economic system that hemodynamic optimization is associated with a decrease of healthcare spending because you avoid complications. So it should not be a debate anymore.
It should not, but
it is still.
It's not reality. So thank you.